Well, welcome. Can you hear me? Welcome to the APOA Hand Upper Limb webinar. This is the sixth session of the webinar run by our society since our inception last year, and indeed the first one for 2022. Today's webinar, we're focusing on compressive neuropathy in upper limb. My name is Ted Ma. I'm from Australia, and I welcome all our members of APOA Hand Upper Limb Society of 14 countries, our more general APOA membership of 26 countries, and many more that log on today beyond our region, including Europe and America. So it's good evening from me, and good afternoon in the Middle East and West Asia, and good morning for Europe and America. Today's program will focus on nerve problem in the upper limb, in the shoulder region. The speaker is Dr. Padiwala from Mumbai in India, with Dr. Guto as moderator from Japan, and Dr. Shiti as commentator from India, Mumbai as well. In the elbow section, committee member Michael Falk and myself will be talking on cubital tunnel and radial tunnel syndrome. And the moderator will be Dr. Al Dafa from Saudi Arabia and Dong Kim from Korea. In the hand section, we focus on carpal tunnel today on open versus endoscopic release by Michael Mack in Hong Kong, followed by the failed carpal tunnel syndrome surgery by Andrew Chin in Singapore, and the moderators Edmund Yao from Hong Kong and Rebecca Lim in Singapore. Next slide. Just a note on the webinar interaction. There will be some questions that will refer to you either during or at the beginning of the talk, so they do give some feedback onto us in terms of their level of experience and interest. Please use the Q&A features only to ask questions. The moderators will collect all submitted questions and for the speakers to respond to. And bear in mind that if there's running out of time, the speaker will still respond to the question afterwards. The certificate of attendance will be given following completion of the post-webinar survey. And this session has been videotaped. So for those of you who either miss out or have to stop in halfway through, you can do that later on at your own leisure. So let's begin the session now with, on the shoulder section with Professor Guto as the moderator. Professor Guto, over to you now, please.
Good afternoon, everyone. I'm Hideyuki Goto from Nagoya, Japan. It's a great honor for me to moderate the APOA hand and upper limb webinar about the compressive neuropathy in upper extremity. The first session is about the shoulder section. I would like to introduce the speaker, Dr. Padiwala from India. And also I would like to introduce the commentator, Dr. Shetty from India. So we would like to start the talk because of the short of time. So please start the lecture, Dr. Padiwala, about suprascapular nerve entrapment syndrome. Please.
Thank you, Professor Goto. It's a great honor to be here with all of you, and I'm going to talk on suprascapular nerve entrapment syndrome. We'll start first with a short case, and we'll have a poll question based on that case. So this is a 36-year-old male triathlete who felt sharp pain in his right shoulder while performing a bench press 8 months before he presented to me. He's had persistent, mild posterior shoulder pain since this episode. And over the past 4 months, he's now noticed progressive weakening in the shoulder while performing his strength training. And when you look at that shoulder clinically, you see that there's marked atrophy of the infraspinatus. There's some posterior joint line tenderness. There's significant weakness of external rotation, but he's got a full active and passive range of motion, and his instability signs, including those for posterior instability, are negative. We get an MRI done, and you can see here on the axial cuts that he's got a posterior labral tear And from that posterolateral tear, he has a paralabral ganglion that's going to the spinoglenoid notch. It's quite a large ganglion there, as is also seen in these cuts here. That's the posterior tear, and that's the ganglion there at the spinoglenoid notch. We can also see this very easily in the coronal cuts. That's the cyst there in the spinoglenoid area. So this is the three important views on the MRI: a posterolabral tear, a large paralabral ganglion. Now, since we've had atrophy and weakness, we got the EMG and nerve conduction study done, and this is showing us severe active right suprascapular neuropathy. This is primarily involving the inferior branch to the infraspinatus. The supraspinatus itself is intact. So what we've got now is a clinical, radiological, and electrophysiological diagnosis there of a suprascapular compressive neuropathy. This is secondary to a spinoglenoid ganglion with a posterior labral tear. The poll question now: what treatment would you offer this player? Would you offer him non-operative treatment in the form of shoulder rehab? Would you do an ultrasound guided cyst aspiration with a corticosteroid injection? Would you do an open spinoglenoid cyst excision with a suprascapular nerve neurolysis? Or would you do an arthroscopic spinoglenoid cyst decompression or excision with a posterolabral tear repair? I'd request all of you to go ahead with your choice, and we'll have the answer coming to us within 10 to 15 seconds. All of these, mind you, are valid options under certain circumstances. Erica, may we have the result now, please? And we can see that at least 60% would feel that an arthroscopic cyst excision is the way that they would go. But as all of you can see, in different circumstances and in different scenarios and with different sort of surgical approaches, you could have valid non-operative and operative options. And we'll see all of these in this particular lecture. So let's first understand what the suprascapular nerve anatomy is all about. So the suprascapular nerve is a branch of the upper trunk of the brachial plexus. It gets its contributions from both C5 and C6. The nerve courses anteromedially to posterolaterally to the posterior triangle of the neck. And this then passes through the suprascapular notch medial to the coracoid. So that's the coracoid. It goes under the transverse scapular ligament and passes underneath there. It then sends off a branch to the supraspinatus. It courses, progresses towards the spinoglenoid notch, and then from here, it gives off branches to the infraspinatus. Now, these are the two areas where you could land up with compression. You could land up with compression either at the suprascapular notch area, or you could land up with compression at the spinoglenoid notch area. So these are the two important areas that we need to note. Also of importance to note is that the suprascapular artery usually lies, it doesn't go through the notch, it lies superficial to the transverse scapular ligament, and it doesn't go underneath it unless you've got a congenital anatomical variant. Now, when you've got a suprascapular neuropathy, it's not necessary that all your patients will have a compressive neuropathy. You could either get a compressive neuropathy or a traction non-compressive neuropathy. Now, the common compressive neuropathies are usually entrapment secondary to paralabral ganglia. You could also get it because of an ossified transverse scapular ligament. And at some point of time, we believe that massive rotator cuff tears because of traction could also cause compression at the spinoglenoid notch. But that is really a debatable cause for compression in today's day and age. We do know that many overhead athletes can land up with traction neuropathies, and this is primarily because of the sling effect. You've got volleyball players, swimmers, tennis players who in their overhead movement with repetitive and extreme overhead abduction external rotation will land up with a stretch effect, and this sling effect will over time give you a traction neuropathy of the suprascapular nerve. You could also get post-traumatic single injuries where you've got traction and suprascapular neuropathy, or you could sometimes get it because of anatomical variance. If the vein or the artery is in the suprascapular notch going underneath the transverse scapular ligament, this itself could cause impingement on the nerve and some amount of neuropathy. Now, typically, most of the compression neuropathies caused because of entrapment will be treated surgically, and those because of traction would be treated non-operatively. Now, how do we diagnose a compressive neuropathy of the suprascapular nerve? And although it's been described as a diagnosis of exclusion, I would point out to you that if you did look for this astutely clinically, you could suspect it. And if you suspect it, you'll do the MRI and the EMG. You can certainly pick it up quite well. Now, most of these patients will come to you with vague symptoms of posterior shoulder pain and weakness. But it's your clinical examination, if you were to make sure that you actually look at the posterior aspect of the shoulder, if you notice any atrophy there, this gives you a straightaway signal that this is a suprascapular nerve entrapment. Most of these patients will have posterior shoulder pain. They'll have some tenderness. And when you look at the scapular region, you'll find that there's either infraspinatus atrophy or infraspinatus with supraspinatus atrophy. And when you check for the external rotation strength, you'll find that there'll be marked weakness of this. And this itself should give you a clinical diagnosis that there's some neuropathy of the suprascapular nerve. You would then go ahead and get an MRI done. And when you get an MRI done, in the entrapment neuropathies, you'll probably notice a cyst or sometimes a soft tissue lesion causing entrapment and compression. And when you look at the coronals, you'll see that classical cyst there, and that cyst goes from the shoulder, and this is the inferior branch of the suprascapular nerve at the spinoglenoid notch, and you'll find compression in this area. You'd also see it well in the axials. In the axial view, you'll typically see that these patients will have a labral tear, and this could either be a superior labral tear or a slap tear or a posterior labral tear. And from that labral tear, some of that fluid is going to seep out, and you sometimes will see a track there. And from that track, you'll find that there's a spinoglenoid cyst. This could be uniloculated or multiloculated. And this cyst causing compression then causes the neuropathy. In some patients, if you've had long-standing neuropathy or you've had a traction neuropathy, you could actually see denervation changes in the muscle. So in the supraspinatus, that's the infraspinatus. So as soon as you see both supra and infra showing you denervation changes, you know that the lesion site is at the suprascapular notch and not at the spinoglenoid notch, because the suprascapular notch is the area where you'd get your branch going both to the supraspinatus and the infraspinatus. Whereas if you see it only in the infraspinatus, you know that it's probably in the spinoglenoid notch, because your inferior branch is the only one getting compressed. The supraspinatus has been spared, so there's nothing at the supra, it's only at the spinoglenoid notch. And classically, if you get an EMG nerve conduction study, this becomes conclusive. When you do your EMG, you'll find that if it's just the infraspinatus, again, you know that your lesion site is the spinoglenoid. And if you get both supra and infra, then you know that your lesion site is the suprascapular and not the spinoglenoid. So you can get a good diagnosis based on clinical evaluation, but it's confirmed on MRI and on the EMG nerve conduction study. Now, we saw what those treatment options were, and all of these 4 treatment options have been described really well in literature. Non-operative treatment classically is for the traction injuries. It's not so successful for the entrapments, for the compressive neuropathies. And so I would recommend that you consider this only for your traction injuries, where on the MRI, you don't really see compressive lesions. If, however, you see a compressive lesion, excuse me, you've got 3 options there. You could do just an ultrasound guided cyst aspiration with a steroid injection, but typically literature shows us that these tend to recur more commonly. So if you just aspirate a cyst, because the labral tear is still persistent, because that valve-like tract is still persistent, these will usually fill up very soon and give you recurrent symptoms. However, if you've got a patient who's a sportsman, he's in the middle of his season, his neuropathy is not that significant, it's short duration, you think that you could maybe just tide over the crisis, get a little bit of time, and then go ahead with the surgical procedure after 2 or 3 months, then maybe you might want to do this as a temporary procedure. Open spinoglenoid cyst excision with suprascapular nerve neurolysis has been described, and you could do it at the suprascapular notch area with an anterior approach. You could do it at the spinoglenoid area with a posterior approach, but both of these open approaches are relatively morbid because you will have to, in the posterior approach especially, dissect, go through the trapezius, and this is a rather difficult approach to do because it's a deep area. Moreover, if you don't repair your labrum at the same time, then it's likely to recur. And therefore, more often than not, most surgeons now over time have moved to arthroscopic techniques, because an arthroscopic spinoglenoid cyst or an arthroscopic suprascapular notch cyst gives you a good access, and at the same time you can not only decompress or excise the cyst, but you could also do a labral repair. So arthroscopic surgery allows you not only decompression but also labral repair, and therefore seems to be the technique of choice in today's day and age. Now, we've noticed that most of these cysts are either focal or extensile. So if they're focal, from the tear, they will go only into the spinoglenoid area. The extensile ones are the ones that from the spinoglenoid area go also to the suprascapular area. And I think that the approach when we do these arthroscopically needs to be a bit different. When you're doing a focal cyst, you could very easily go through the translabral approach, through the area where your valve is, approach the cyst and excise it. Whereas if you've got an extensile cyst and you have to go both to the spinoglenoid and to the suprascapular notch area, then you'll need a paralabral, a transcapsular approach. And I'm going to show you both of these approaches. So let's see the first one. And this is a focal cyst in the spinoglenoid notch. And I'm going to show you the translabral approach. So this is the cyst seen on the MRI. So you can see it on the coronal, the axial, and the sagittal view. It's a large multiloculated cyst. The patient's got a suprascapular neuropathy. The patient is now in the lateral position. And this is the way that I'd start. So I'm looking at the shoulder. Patient is in lateral position. That's the humeral head. That's the glenoid. That's the posterior labrum. And looking at it from the standard posterior portal, you'll first note that that's the labrum here, which is a little frayed, and this is the area of the cyst. I will take 2 portals. The probe is now coming in through the anterosuperior portal, and from this, I will note where that labral cleft is. Once I've cleaned it up a bit, I'll put my scope now into the anterosuperior portal, and my probe is now coming in through the anterior portal. So this is anterior. My instruments are coming in from the anterior, and that's the posterior portal there. The first thing I do is go through that labrum where the cleft is. And when you do that, you'll note that this is some of that ganglion fluid, the mucinous fluid from the ganglion coming out there. Now, some surgeons believe that all you need to do is decompress the cyst. You just need to decompress the cyst and go ahead with your labral repair. I think that's okay if you don't have a neuropathy. If you've just got a painful cyst without a neuropathy, I think that's okay. But if you've got a neuropathy, I think it's important for us to actually decompress, excise the cyst, see the nerve, and if necessary, also do a neurolysis. So now I'm looking through the anterosuperior portal. I'm looking through my labrum. So that's the glenoid, that's the labrum. This is the translabral approach. So I've got the view there. And with the shaver, I've now taken out a small amount of the cyst. You can see that that's the hole there. And you start sucking out all the mucinous ganglionic fluid from that ganglion. So that's all the fluid coming out. Now, a lot of these cysts will be multiloculated. So it's not enough to just see one cyst and evacuate it, because you might have another cyst sitting there on the nerve that you've not really identified and not really taken out. So you start using your shaver, do this very carefully, very slowly, and you do this till you start seeing the fat. As soon as you start seeing the fat, then you know that you've gone all the way through. You excise your entire cyst wall, and now you'll note that that really is your spinoglenoid area. This is the bone there, so you can feel that with your probe. And once you've felt that with the probe, you know that this is now your area of the spinoglenoid notch. This here is the nerve. And I'm going to show this depth to you. So that's the glenoid, that's the labrum, that's the opening that we've made. You can see that you need to go down at least 3 centimeters into the spinoglenoid notch. And you note that that's where the notch is. You can then put your probe and identify the nerve. Once you've identified the nerve, if you find that that nerve is not really compressed, it has no stenotic areas, you can see that the branches going to the infraspinatus are not really compressed, then you don't need to do anything further. I'll show you in the next case where you may need to do a neurolysis. You then go ahead and prepare the rim and put in your suture anchors and do your posterior labral repair. As routine, I think it's important to repair the labrum back, because this then shuts down your cleft, it shuts down the valve, and this ensures that you will not have recurrence. So you've done your labral repair, you've excised the cyst completely, you've taken out all those multiloculated cysts, you've identified the nerve, you've decompressed the nerve, and this is, I think, the best way to ensure that you don't land up with recurrence. Coming back to that first case that I showed you for the poll question, what did I do for that? So this is exactly what I did for that. Translabral approach, because it's a focal cyst. Again, you open it up, you'll see the cyst wall there, and I think it's important to get that whole cyst wall out. You'll note that he had a lot of atrophy because this was a chronic case. And when you go down, again, you've taken out all that fat there, you'll note that that nerve is very stenotic, it's thin, but it's intact. And as soon as you see the vascular pulsations here, then you know that you've landed up with enough decompression, and there's nothing further, no fibrotic sort of bands holding the nerve together. And then that completes your decompression. And of course, once you've decompressed it, you also need to repair it. So a standard arthroscopic posterior labral repair. And I think that this is the beauty of an arthroscopic approach, because this allows you to take care of all of the pathology, not just the cyst, but also the labral repair, and do it easily and quite elegantly. Now, if you don't have the means to do an arthroscopic, by all means do it open, but then you must repair the labrum back. You must do an open posterior labral repair, because if you don't do that, your chances of recurrence are going to be high. What about the transcapsular approach? So sometimes you're going to need to do a more extensive job, which you can't do through a small translabral approach. So when you've got a large cyst that goes from the spinoglenoid to the suprascapular area, and you've got both the supra and the infraspinatus involved, these are extensile cysts, and these will be treated a little differently. So let's see one more case example. So this is a 43-year-old right-handed ex-fast bowler who's now a coach, and he's been having posterior shoulder pain, weakness, and an inability to perform his throwdowns, which he has to do to his students since the last 9 months. And you'll note that there's not just infraspinatus atrophy, but there's also a significant supraspinatus atrophy. And his MRI is interesting. So let's see this in sequence. So going now from anterior to posterior, the coronal cuts, you'll note that that's the coracoid, the subscap. This is the area of the suprascapular notch, and you'll see that that's the cyst out there. And as we go more and more posterior, you'll note that this is a large cyst, and it's communicating right down to the spinoglenoid area out here. Again, when we see this in the axials, let's see from inferior to superior. From inferior to superior, that's the humeral head, that's the glenoid, that's the cyst that we are seeing in the spinoglenoid area. And as we're going more and more superior, you'll note that there's some amount of labral degeneration, but there's a huge cyst that goes from the spinoglenoid to the suprascapular area. And finally, when we see this in the oblique sagittals, you'll note that that's the cyst in the spinoglenoid notch and progresses anteriorly into the suprascapular notch. And because it's a little chronic, you can also see that it's eroded off some of the bone there near the suprascapular notch. So how would I approach this? So again, the patient's in lateral position. In this patient, I'm going to do it's going to be a transcapsular approach. So what do? I do a small little arthrotomy here. I do a small little capsular incision here. And then as soon as you've done that, you'll straight away go down to the cyst because the cyst is so large. Now, once you're at the cyst, identify the cyst. With your shaver, you can open up a little bit of the cyst wall, and you'll note that that's the cyst wall there, and enter into the cyst. Now, once you enter into this huge cyst, you can actually travel all around, see all of the multiloculations there, and get a good idea of what you need to excise. And then with the shaver, you dissect it off, excise off all of that cyst wall. I think it's important in these patients with large multiloculated cysts to actually try and get all of that cyst wall out so that you don't land up with small recurrent cysts, which may cause residual compression or may at times cause some residual pain. Now, once you've got all of that cyst out, I'm looking from the posterior portal, and looking from the posterior portal, you'll note that that is the suprascapular nerve, and this is the area of the suprascapular notch. Now, at this area of the suprascapular notch, get a good idea of your anatomy. You've already taken out that cyst. That cyst has done a lot of your dissection. You'll note that this is, because it's chronic, in a slightly more fibrotic state. And in these patients, when you've got these fibrotic bundles, I think it's worthwhile also to do an arthroscopic neurolysis. You would certainly do this if this was an open case. So why not do it when you're doing it arthroscopically? Now, how do you do this? Well, first you want to make sure that there's nothing entrapping, there's no fibrosis, there's good excursion of the neurovascular bundle. And once you've confirmed that, then with your probe, you slowly start teasing off all of the fibrous tissue which surrounds it. You need to be a little gentle here. And if you find that this is very tough, which we have faced in a few occasions, I'll have my assistant hold the scope, whereas I'll put in another portal through the Nevacia portal. And then with my two hands, I'll go ahead and dissect out that entire neurovascular bundle. Now, once I've done the suprascapular area, I'll come now to the spinoglenoid area. So I'll shift my scope to the anterosuperior portal, and I'm looking down into the spinoglenoid area like we saw for the previous cases. Now, once we've done that, you've identified the inferior branch. So this is the branch, the inferior branch, which is going to the infraspinatus. This is in the spinoglenoid area. Again, a lot of fibrosis here because this is a chronic cyst. And so again, you need to slowly tease and take off all of this fibrous tissue that's strangulating the nerve. And once you've done that, then you'll find that you've got a nice neurovascular bundle that's free right from the suprascapular area right down to the spinoglenoid area. And although you might see, it might at times seem a little daunting, typically, the cyst has done most of the dissection. As soon as you get into, you do your capsular release and you get into the cyst, you'll find that all of this area is already dissected out by the cyst. So you don't have to worry too much about, would you be damaging anything else? You just need to be a little careful when you're excising the cyst wall. Now, at times, we've also had to do approaches at the suprascapular nerve area for traction injuries which haven't recovered. So like this patient that I showed you earlier, who's got both supra and infraspinatus involvement, you would probably need to go directly to the suprascapular area. And this I would do through the subacromial space. So if I've got nothing there in the spinoglenoid area, I don't need to go via a glenohumeral arthroscopy. That goes directly from the subacromial space, do a bursectomy, identify the CA ligament. From the CA ligament, go to the coracoclavicular ligaments, and that, when you trace down, will go to the transverse scapular ligament here. And once I've identified that, I'm going to resect off the transverse scapular ligament and make sure that, again, my nerve out here, so that's the suprascapular nerve out here, has a good excursion in the suprascapular notch. And once I can make sure that I've got a good excursion, there's nothing compressing it there, you've got no residual stump of the transverse scapular ligament coming the way, then I know that my job is done. And you'll see here, post-op at 3 months after the release, you can see that already those denervation changes are getting reversed. So what sort of outcomes can we expect in these patients with suprascapular neuropathy? So we did a study a few years back, which I presented at the Upcast too. And we had 27 consecutive patients who underwent an arthroscopic decompression of their ganglion cysts. And all of these were associated with a suprascapular neuropathy. And all of these patients had concomitant labral repairs. And we divided the groups amongst the focal cysts, where we did a translabral approach, and the extensile cysts, where we did a paralabral approach, and 2 extensile cysts, where we did a translabral approach. And on the whole, what we found was that if you did an arthroscopic approach where you got the cyst out, you released the nerve, and you did a labral repair, then almost all of these patients are going to have excellent recovery of their pain, function, and external rotation strength. And when we had done post-op MRIs in 24 of these patients, we found that you had no recurrence. Whereas if you couldn't take the entire cyst out, which we did face when we did a translabral approach with the extensile cyst, then you could have some amount of a recurrence. We also found that post-op EMGs will give you reversal of the changes in the infraspinatus. But however, the post-op EMGs never get back to a completely normal EMG, but they will be much better than they were pre-op. And none of these 25 patients had any clinical or symptomatic recurrences in their follow-up. We've also shown that the mean ASES scores showed significant improvement from pre-op to post-op with these arthroscopic approaches. And these results mirror the results of many other similar studies done by JCU from Korea. JP Warner's done these similar studies. So multiple papers to show you that an arthroscopic approach where you do excise the cyst and release the nerve would give you good outcomes. Finally, in conclusion, to diagnose a patient with an entrapment neuropathy of the suprascapular nerve, you need a high index of suspicion. If you pick them up clinically, you get the MRI done, you're going to have an immediate diagnosis, confirm it with the EMG nerve conduction study. Although open approaches are possible, they're slightly morbid and difficult. So if you do have an access to an all arthroscopic approach, I think that would be ideal, because then you could get to the suprascapular notch, you could get to the spinoglenoid notch, and this allows better visualization, less morbidity of approach. It facilitates a complete dissection of the cyst and excision of the cyst, and at the same time allows a labral repair. However, you need a thorough knowledge of the anatomy and the arthroscopic sort of view and arthroscopic anatomy, and your soft tissue technique needs to be a little refined, because you'll be working with 2 portals and just about a probe and maybe 2 probes there to do your neurolysis. Thank you.
So thank you, Dr. Dinshaw, for this wonderful presentation. I think you've covered the entire spectrum of entrapment of the nerve from the spinoglenoid notch to the suprascapular notch. The first question, as the moderator is looking into the poll questions to you, is the first controversy regarding the repair of the labrum. So we do see this sort of cysts and tears in slightly elderly, low demand individuals, ladies, etc., in whom the tissue is not very good quality also. So are you a proponent of repairing them always, or do you have an exception for repairing the labrum?
So I think we need to divide these patients into 2 groups. The patients who have a spinoglenoid ganglion without a neuropathy, and those who've got a neuropathy. I think if they've got a neuropathy and you're going to go and do your complete cyst excision, and you're going to do it through a translabral approach, then your tear, I mean, you might initially have had a small little rent in the labrum, but if you're going to do a translabral approach, you've actually had to extend that tear. So you do land up with a significant sized posterior labral lesion. I think it's important to go ahead and repair the posterior labrum in all of these scenarios, because otherwise your chances of residual instability or your chances of a recurrence become higher. Now, if it's an older patient whose main symptoms are only pain and not a neuropathy, and you're going to do just a cyst excision, you may just do this as a subacromial approach, or you may do this as a transcapsular approach. And in these situations, you may not necessarily go ahead and do a labral repair.
So therefore, coming to the second question, in your protocol, you would be doing an EMG NCV study in every patient to make sure that the neuropathy component is there and it's not just the pain component which the patient you are addressing at. Or is there an exception again? So that is another debate, whether you need an EMG in every patient. So in the young patient, yes, because you need to prognosticate him, you need to counsel him that his changes will not reverse. But would you do that the same in the elderly, low demand paralabral cyst with the small degenerative tear?
So I think two things. When you're doing your clinical evaluation itself, as soon as you've got an atrophy of the muscle, you know that this is a long-standing neuropathy. As soon as you've got weakness of external rotation, you know that there's definitely a neuropathy component. So that gives you your clinical evidence that you've got a neuropathy. Your MRI may show you changes of neuropathy because of denervation changes, but it's really the EMG which gives you your complete picture. It also lets you know if those changes are irreversible. Sometimes you'll get a chronic denervation and you're going to get irreversible changes and your patient doesn't have much pain. He's come to you only for the weakness. If he's had those changes going on for years, I'm prognosticating him and telling him, look, we could do the procedure, but I'm not so sure that you're going to get your strength back. And if you're doing the procedure just for strength, then this gives me a good prognostic indicator that maybe I don't need to do the procedure because he's got no pain and my procedure is probably not going to give him strength because he's got significant atrophy going on for years on end. And the EMG shows me that he's got irreversible changes. Then those are the cases that I'd say, look, I don't think surgery is going to help you. So I think an EMG is very important.
And regarding the technique, so you showed wonderfully, and obviously with your level of experience, it is possible for using the shaver in that dangerous territory. But we do know there are anatomical variations. And when we are using the shaver to dissect in that, there is a very high incidence of the nerve or one of its tributaries getting caught up. So what would be your advice for the beginners as to what should be the modifications in the technique? Can they go subacromial? Can they approach the spinoglenoid notch separately and the suprascapular notch separately? So would you shed some light on that?
Now, there are many approaches to the spinoglenoid notch area. You could go from the subacromial space. You could go from the glenohumeral space. You could go translabral. You could go transcapsular. Now, the tip here is that when you go glenohumeral and you go translabral, that's the most anatomic approach because that's where the labral rent is. That's where the tear is. And you basically are just going to follow that track down to the cyst. Now, when you're going from the glenoid to the spinoglenoid notch area, remember that your cyst comes first and the nerve comes last. So as soon as you've done you've opened up the labrum, the first thing that you're going to see there is the cyst. You take off a small portion of the cyst and you're in the cyst. Now, once you're in the cyst, you are very safe till you reach the end of the cyst. So you can dissect off the wall, take it off very easily with the shaver without too much of a problem. But as soon as you go towards the end of the cyst, that means deep down, you need to be a little careful. What are the tips there? Don't dig your shaver in. Make sure that your suction is not kept on full where you may suck in some tissue there. And usually once you've taken off the last part of the cyst wall, you will see some amount of fat. So as soon as you see the fat, you know that now there's no further cyst. There's no need of the shaver anymore. You'll see that typically I don't use too much of a radio frequency device there because that could cause problems to your nerve. And then with my probe, I will gently tease off any of the fibrous tissue there. So I think it's a relatively safe approach if you have your arthroscopic anatomy and your three-dimensional sort of visualization of that joint. If you've got that and you've done one or two cases like this, I think it becomes a relatively simpler approach. If you try and go from the spinoglenoid area towards the labrum, as you can sometimes do when you're doing a subacromial approach, I think that could be a little dangerous. It's always better to identify the cyst, and after the cyst would come the nerve.
I have a few more questions, but Professor Goto, is there anything from your side or from the audience?
Yes, I now see the about the treatment options for labrum repair. Should we go with low focal or extensor decompression along with the labral repair? And a posterior instability is related to this kind of pathology? That is the question that we have.
So I think that's a really interesting question. We often find that a lot of these patients with posterior labral, paralabral ganglia don't necessarily have posterior instability. The posterior instability patients typically have larger labral tears, and probably because they have got larger labral tears, there's no valve-like mechanism. So the fluid doesn't then collect and form a ganglion. They typically have smaller tears, and from those smaller tears, then that's a valve mechanism from which the cyst forms. So very rarely would I see a patient who's got posterior instability, clinical instability with a posterior labral ganglion with neuropathy. More often than not, this is a labral tear. I think it's important to repair that labral tear, but you're repairing it because of your approach and not necessarily because of instability. I think if you left it alone after your translabral approach, yes, you could probably land up with iatrogenic posterior instability.
Okay, thank you very much. Very interesting that you show that the extensor cases for using transcapsular approaches. That is really successful, especially for severe cases. So far that you are trying to do these kind of approaches with every cases when you see the extensor cases?
So with the extensile cases, you could also go very effectively from the subacromial approach. From the subacromial approach, again, you can go to the suprascapular notch and you can go to the spinoglenoid notch very, very easily. So you could either use the subacromial, but I tend to use the transcapsular only because many of these patients also have some associated intra-articular problems. So if I'm going to go into the glenohumeral joint and I'm going to be doing anything intra-articular, then at the same time, I can easily do a transcapsular, and this gets me directly there to that cyst. So if you note from the MRI, often these cysts are lying just below the edge of the labrum. So if you just do a little bit of an opening there, the cyst is right there, right in front of you. And then once you enter the cyst, you can go all around. So it's just an easy surgical technique. Whereas if you have to go from the subacromial space, you will have to do a significant amount of removal of subacromial bursa before you actually get to that area.
Okay, thank you very much. So now time is up that we'd like to all the audience and the speaker well, maybe they'll answer more questions after the sessions. So please move to the next session.
Thank you. Thank you.
Thank you very much, Dr. Valdez and Dr. Shetty.
Thank you.
Yep.
Hello, everyone. Okay, you can change the camera, please. Oh, okay. So good afternoon, everyone, and those who are at a different time zone. If you can just focus the camera on me, Basma. So we'll have now the elbow session, and then I'll be the moderator, and then Dr. Dong-Hee Kim will be the commentator, and then we have two exceptional speakers, Dr. Margaret Falk and Professor Tedma. So if you can go to the next slide, please. Okay, so this is okay. So these are the CVs for our presenters today. Both of them, Professor Tedma and Dr. Margaret Falk, and also the commentator, Dr. Dong-Hee Kim. So we'll have an interesting session today that is involving the compressive neuropathies of the elbow. And then we will have like a small session of discussion following every presentation. So if you can go to the next slide, please. So this elbow session will start by Dr. Margaret Falk. She will talk about the cubital tunnel, and then she will include also a poll that she will run. So the camera should go to you, Dr. Margaret.
Thank you. Thank you, Basma. So good morning, good afternoon, and good evening to everyone who's today who joined the webinar. So today I'm going to talk about the management of the cubital tunnel syndrome and the current concepts. So why we talk about cubital tunnel? Because this is the second most common peripheral nerve compressive neuropathy, with an incidence of 25 cases per 100,000 per man per year, and 19 cases per 100,000 per woman per year in US. And the presentation is usually later in the carpal tunnel syndrome, with presentation of muscle atrophy and loss of sensation. So when we talk about our nerve neuropathy, what are we talking about? Well, basically, we are talking about our nerve entrapment at the elbow region, which is so proximal, about 8 to 10 centimeters proximal to the medial epicondyle, and distal 6 to 8 centimeters distal to the medial epicondyle. And there are a lot of sites of entrapments, usually with the most proximal being arcade abstrusus. Then you've got medial intermuscular septum, medial head of triceps. Then you've got the deformation of the cubital valgus, also part of the medial epicondyle groove. Then the most common one is the cubital tunnel reticulum, which is the osculum ligament. Then you've got anomalies of the conius epichromosis and the deep flexor pronator aponeurosis. So how do the patients present? The patients usually presented with a loss of ulnar 1.5 finger sensation, both volar and dorsals, and also complaint of intrinsic wasting. You have loss of first web space, muscle bulk, like in the clinical photo here, with claw hand of the ring finger and little finger, Frohman sign, Wartenberg sign, which means that you're unable to adduct the little finger. And if you do a provocative test in terms of Tinel sign at the medial epicondyle, where the cubital reticulum is, or you do a flexion compressive test, which means flexing the elbow, the patients will complain of numbness of the ulnar 1.5 fingers. So we can usually cubital tunnel syndrome is a clinical diagnosis. However, we can usually confirm it through nerve conduction tests. And nowadays I tend to do them because it will confirm my diagnosis, assess the severity, and to do a prognostic value to see how much it may improve, especially if you do EMG as well. And you can show that there is conduction block across the elbow with decreased SNAP and CMAP. Sometimes we also do X-ray of the elbow, especially if we suspect that there's cases of previous trauma or that there's osteoarthritis of the elbow. This is the classification of cubital tunnel syndrome, which is the Dellon's classification and also McGowan's classification. They're quite similar in terms of describing them into mild, moderate, and severe, with the mild being more subjective feelings, and the moderate and severe is there has actually objective neurological deficit. So now the most important question is, how do we manage them? Do we do it conservative or surgery? So let's start with a poll question. This is a 72-year-old gentleman, left ring finger, little finger numbness for 6 months, associated weakness of the right hand, decreased light touch sensation of the left ring finger and little finger, and clawing of the ring finger and the little fingers. The Frohman sign, Wartenberg sign, power of the FTP is slightly decreased. Tinel sign at the elbow with the elbow range of movement of 20 to 120 degrees. NCV also show that there's ulnar nerve entrapment at the elbow region. So that's the question. So how would you treat them? Will you treat them conservatively, or will you do an open decompression? Or will you do an open decompression plus anterior transposition? Sometimes people will still think about doing medial epicondylectomy or endoscopic decompression. So could we have the result? Okay, so it's quite interesting because about 1/3 will say that they will still do open decompression in situ, and 1/3 would tend to do open decompression and subcutaneous transposition, and some will do submuscular transposition. Let's go to the second one. This is a 35 years old gentleman, so it's likely younger, on and off right ring finger and middle finger numbness, precipitated by activities which involve elbow flexion. Sensations normal on examination. Finger abduction is slightly weak. Tenelsa is positive. Ulnar nerve subluxation noted at elbow, and NCV showed mild to moderate ulnar nerve entrapment. Again, can we please have the poll? Do we still try to use conservative treatment? It is, remember, this is a younger patient, or will we go for surgical? Do we do just decompression alone, or do we do anterior transposition? There's also options of endoscopic, and then I think that depends on where you are and whether there's availability of the instruments to see whether you can do it. So can we have the poll and result? Okay, now I can see that there are more people who will just do and will do open decompression and anterior transposition, but there are still some that will only do decompression in situ. Okay, so I'll go back to, so I'm going to start my talk and I'll go back later and describe what I did. So when we talk about treatments, of course, we cannot forget about conservative treatment, which includes activity modifications, which we teach our patients to avoid direct pressure to the medial aspect of the elbow, repetitive tricep strengthening exercise, and to avoid prolonged rest in elbow flexion. We can also prescribe them with splint, either very hard rigid splint or soft splint, which basically is to try to avoid elbow inflection. There are some talks about doing nerve gliding exercise, basically asking the patient to hold the elbow in different positions and then gradually move them and so that they will have more gliding. There's also talks about steroid injection, although there isn't any really good evidence that said that there is improvement. So it's been, so far looking at the literature, most of the conservative treatments are good for mild to moderate ulnar nerve entrapment. Schurz said that there is 25 elbows with 3 months of conservative treatment in terms of activity modification and rigid night splinting. At 2 years follow-up, there's 88% improvement. And there's another study, which it is a randomized controlled trial study involving 70 patients with mild to moderate cubital tunnel syndrome. They actually talk about activity modification alone, plus activity modifications with night splinting, or activity modification with nerve gliding exercise. And follow at 6 months. Within 6 months, 10% actually underwent surgery anyway, but the remaining have significant improvements in terms of the VAS score, performance score, and the satisfaction score. But interestingly, there's no difference between the 3 groups, which means it seems as though the activity modification is the way to go, and night splinting and nerve gliding exercise may not have any significant added benefit. So, but when should we operate? Well, Jennings has this study in 1993, which shows that 129 patients with about 5 years follow-up. And we find that for the mild groups, only 21% will actually will actually proceed with operation. Moderate, about 1/3 of them. The severe groups, about 2/3 of them will need to go under surgery. So our indication for surgical intervention is failed conservative therapy, preferably confirmed with NCV, or that the patients presented with severe neurological deficit. So there, as I said, there's different surgical management in terms of either decompression in situ or with anterior transposition. You can do subcutaneous, subfascial, submuscular, or intramuscular. Then you have the open release or endoscopic release, and as well as that, you have medial epicondylectomy. But how to choose? Which one should we do? So we go back to literature and then we try to find out what we can do. So first, what do we want to achieve? We want to decompress the nerve, especially at the cubital tunnel, which is the arcade of, which is the ossified ligaments, as well as that we want to, if possible, we want to, because sometimes it's not just the ossified ligament, although most of the common site, it is still at around the elbow region, but we want to go proximally to the just 8 to 2 centimeters proximal to the medial epicondyle, to the arcade obstructus, and to the branches of the FCU. So when we do a decompression, that's what we are trying to achieve. And for the outer nerve with release and anterior transposition, we actually transpose it to a different route and try to avoid the same route, so that in case, for example, there is space occupation or the bed is not very good. So we transpose it and we try to use a subfascial sling. Then we can also do submuscular, which is slightly more invasive because we are basically elevating the whole flexor and pronator muscle bulk, and then we put in the nerve down there, and then before we paired it. And usually it is for very thin patients or for salvage procedures in most of the cases. As for medial epicondylectomy, we do an oblique osteotomy between the sagittal and coronal planes of the medial condyle. We have to make sure that we do not take too much of the medial epicondyle, otherwise the patients may have elbow instability and also elbow pain. So we want to preserve medial collateral insertion, and we do a slightly, so it's in between anterior transposition and decompression in situ, because we change the outer nerve root a little bit by allowing some anterior translation and reduce less of the nerve strain. But the complication, as mentioned, is the patients may have medial elbow pain and flexion contraction. So when we compare all these different techniques, we can group them together. So there's a decompression in situ and medial epicondylectomy or anterior transposition. And you can see that the incision is shorter in the decompression in situ. The soft tissue dissection is slightly less. Manipulation of the nerve is slightly less. However, the visualization of the nerve, less chance of damage. But then if you want to have away from damaged bed, obviously anterior transposition or medial epicondylectomy is better. If you have outer nerve whether you develop outer nerve subluxation irritation, yes, it is more possible with the decompression in situ. New site of compression, well, there isn't that much in the decompression in situ, but you've got more in the anterior transposition or medial epicondylectomy. Postoperative immobilization, of course, you don't really need to do it in decompression situ, but you need to think about it in medial epicondylectomy or anterior transposition. And so because the smaller wound, less soft tissue dissection, the recovery tends to be faster in decompression in situ as opposed to anterior transposition or medial epicondylectomy. But these are some of the comparative studies that compare them. And you can see there is a lot of randomized controlled trials that talk about whether we should do decompression in situ or whether we should do anterior transposition, which in this case, it includes either subfascial or intramuscular. Also, there's mixed different grades, but most of them are idiopathic cubital tunnel syndrome. So they're not the ones that who's most traumatic. They're just the idiopathic cubital tunnel syndrome in terms of like osteoarthritis of the elbow. So looking at this, most of them actually have good results no matter what you do, but it is the difference in terms of complication. Anterior transposition tends to have a slightly more complication in terms of damaging the medial antebrachial cutaneous nerve. Also, in one of the studies in Beck, they show that there is increased chance of having deep wound infection. The Cochrane review in 2016 also showed that there's no clinical improvement between simple decompression and transposition. Transposition have a higher rate of infection, and there's no clinical neurophysiological difference between medial epicondylectomy and transposition. And there's no clinical difference between subcutaneous and submuscular transposition. So most of these cases, with this conclusion, most of these cases, it seems as though without any severe subluxation or post-traumatic elbow, it seems as though simple decompression is the way to go, or is being suggested. Nowadays, with the increasing popularity of using the endoscopic decompression, so I'm going to talk slightly about it and then compare our results. So this is the one that we have designated instruments for decompression. There's different kinds. There's the cannula one, and then there's the then you have the specialized dissecting equipment, which is by Storrs and AG. They tend to have smaller incisions, and they have extensive view in the subcutaneous and subfascial view. And it is also a magnified view, so you can see it more clearly. So these are the proposed advantage. However, there's some contraindications for endoscopic decompression. For example, the presence of space occupied lesion, previous trauma surgery to the outer nerve or the elbow, severe elbow contracture, concomitant conditions necessitating open surgery, because might as well, if you do open surgery, you might as well just do the open to release anyway, or the patient's particular condition necessitating anterior transposition. So this is how we go back. So this is a nerve entrapment at the elbow, and you can see the archaea abstrusis and down to the deep fascia of FCU. And what we do is we can take a small incision between the medial epicondyle and the olecranon, and it's just like a 2 centimeters incision. Then we try to find where the outer nerve is, which we can dissect it and we can find it. And then we can use different instruments. This is the one that we use the scope to go in. And we try to, and then we need to develop a plane in the subcutaneous nerve tissue as well as just over the outer nerve, so we can identify where the fascia is, and then we use a knife or scissors to cut it. We can also use the Storrs instruments, which is another one that I tend to use, which is which they have a cannula that basically retract our subcutaneous tissue so that we have a working area. So when we put in the cannula, you can see that. That is in the distal side, so we can see the FCU muscle bulk. And then so we developed a plane which is in the subcutaneous tissue. Now we know where the nerve is by using we still do a simple decompression, and now we use scissors to identify where the nerve is, and then we try to cut the fascia just above it, just above the nerve. Remember that we have to spread, and before we cut, we always have to look to make sure that we can see the tip of the scissors, to make sure that we are not cutting anything further. Then, okay, sorry, I think this is the same one. Yes. So remember, we don't usually cut a lot. I don't usually cut a lot of muscles nowadays because that will cause a lot of bleeding. So I tend to just do the fascia, and then I will spread and then I'll just use the scissors to spread the muscle so that it will not create as much bleeding. And then you can see the outer nerve behind, and then you spread, and then don't close the scissors unless you can see the tip. Otherwise, just pull it out openly. Then we can also, we can also do it. Then we can also do it in the so this is how we done in the proximally. You can see the FCU tendon. Then this is how you do in the proximally. Again, subcutaneous plane, we can see where the nerve is, and then we gradually spread it, and then we cut the fascia. So we can measure how much we can go, which is 80 centimeters above proximal to the medial epicondyle. Sometimes there will be bleeding, and what we do, we identify where the bleeder is. We identify the small vessel, don't cut it and make it bleed, because then that will damage the whole image that you are trying and you will damage, and then you can see the the field. So what you do is, if there is a bleed, if there is a vessel, try to cauterize it before you cut it. Okay, so this is just to show you how you cauterize it. You wait for the smoke to go away. And then before you cut it. Okay, so that there will be less bleeding. And this is an important step because you have to do, because I'm going to talk about what is one of the complication, major complication is hematoma afterwards. So these are the case series results for endoscopic decompression. You can see that there is good result. And as I mentioned, the only downside is that there is patients with hematoma, which can be up to 10%. These are again good results that shows that there are patients with good results in terms of all the case series. And there is a patients with one recurrence and nerve instability. How about if we compare endoscopic decompressions versus open decompressions? Well, you can see that actually they both have good results. However, there's slightly difference in terms of general complications. One of them is that for open, there's still a chance of having more medial and neobrachial cutaneous nerve being damaged, whereas for endoscopic is because of the hematoma. So, again, this is the one that shows that whether you can have, again, the tourniquet time tends to be slightly longer for endoscopic, but that's because that we are actually doing more extensive dissection and decompression as opposed to open. And the scar satisfaction, usually the endoscopic is slightly better. That's the systematic review again with endoscopic and open. Again, we talk about the complication is similar, is the scar and the hematoma. So looking at, well, the short endoscopic seems to be good because the short incision. And if you do and there's a cadaveric study in 2018, which shows that if you do endoscopic decompression, it's a 2 cm versus an open decompression in situ, which is 4 centimeters, and you can see a longer extent and decompress longer. There's also a low risk of nerve damage and faster recovery. However, there's slightly longer operation time and hematoma. And so that's the one that you have to be sure. And I often off the tourniquet to make sure that there is good hemostasis before I close the wound. So how about, can we do anterior transposition? Obviously, there are some cases that we have to do, there are contraindication for decompression in situ, and there's indication for anterior transposition. For example, previous trauma or surgery to the outer nerve or elbow, severe elbow contracture, cubital valgus, and concomitant condition necessitating anterior transposition. There's this one which is slightly debatable, is hypermobile outer nerve. So there's some that is not just completely subluxation, but then after decompression, the patients we noted that we were planning to do open decompression or decompression in situ. And then after that, the patients noted to have hypermobile nerve on full range of movement. So do we transpose them? So there are studies that show about that there's no significant difference between the two groups. But for me, I tend to transpose it because I don't want to do it later on in case a patient do have symptoms later on. But can anterior transposition be done endoscopically? Well, usually the indication is hostile bed and unstable outer nerve, which is preoperative or post-nerve release. However, there are contraindications, and the most important ones, of course, is that we can't do anterior transposition submuscularly endoscopically. So these are the patients that we have to do it open and transposition. So how do we do it? Well, basically, it's similar. We still do the decompression, but then we have to excise them. We have to make sure that we excise the medial intermuscular septum, because when we do anterior transposition, this is the site of compression usually. So we have to make sure that identified it and we have to excise it. And so, and sometimes we actually have to create a new portal to sling the nerve so that it will decompress it better, because now we have decompressed our nerve circumferentially. So we have to sling it and then and then put it into anterior root. So it is like here. And then afterwards, that's how we can see. So this is what happened after we decompress it and then sling it and put it anteriorly. Then we use, that's a smaller incision in front. That's how we do it. And then we use a fascia sling. So it's a subfascia anterior transposition. Postoperatively, because it is still small incision, so I tend to use arm sling and slap for 1 week and then allow free mobilization and light activities. We have moderate to heavy duty or return to sports as around 6 weeks. So unfortunately, endoscopic cubital tunnel with decompression with anterior transposition is quite new. So there isn't that a lot of case series, that a lot of case study to talk about it. So it's mainly case series, and you can see that there's good result, although the complication rate is still hematoma and medial antebrachial cutaneous neoplasia. So going back to our cases. This is the case 1, 72 years old gentleman, which we think that it is decompression of the arthritis of the elbow causing that cubital tunnel syndrome. So for me, in this case, I would do endoscopic decompression in situ, unless intraoperatively I find that the nerve, after the release, the nerve is subluxable. Then I will go and do anterior transposition. The second one is a younger gentleman. For that, because the outer nerve is subluxable early, as I said, it is still debatable. I'm sorry. Although I said that it's still debatable, but for me, I would prefer to do endoscopic decompression plus anterior transposition. So that's my take-home message, is that cubital tunnel syndrome, it is common. Conservative therapy tends to be reserved for mild to moderate disease. For surgical intervention, we can do decompression in situ or anterior transposition. But most of the idiopathic one, we prefer to do decompression in situ, because looking at our literature, it seems as though they have been able to achieve good results. Endoscopic techniques of the elbow is promising, and so we can do a simple release plus or minus anterior transposition, because it allows speedy recovery and no risk of complication. So with that, thank you very much. And I welcome any question. Thank you.
Yeah, hello everyone. We have discussion time. I'm Dong-hee Kim from South Korea. It's an honor to join this nice webinar as a commentator. We will have 7 minutes for Q&A for each presentation. This is section we talk about the neuropathy around the elbow. It was a nice presentation. Thank you for Dr. Fogg. Yeah, cubital tunnel syndrome is common to upper extremity surgeons. Dr. Fogg presents general management for cubital tunnel syndrome and shows nice video of endoscopic decompression of the ulnar nerve. When I was a trainee, the most popular surgical technique was subcutaneous anterior transposition of the ulnar nerve, but now it was changes. In situ decompression, including endoscopic decompression, is getting popular. So recent paper shows in situ decompression, including endoscopic decompression, is the best option for primary cubital tunnel syndrome. Surgical outcome among the surgical technique are similar, but in situ decompression has high patient satisfaction, lower complications, similar recurrent rate. But in my opinion, we should choose the proper surgical treatment according to the patient condition. We have to assess severity of the disease, state of the elbow joint, response to conservative treatments. So I still love the ulnar nerve transposition. So question to Dr. Fogg. Dr. Ostman and you recommend in situ decompression for the cubital tunnel syndrome patient with mild or moderate symptom. But I have many, half of the patients have severe symptom, and they show the very low conduction velocity, and they are hard worker, have to return to work. So how about this patient, the patient with moderate or severe symptom? You still choose the endoscopic decompression or other option?
Yes, I will choose. I would still prefer to do endoscopic. I don't think there's any difference between whether they are manual worker or they are office worker, because looking at the results, they seem to get good results no matter what kind of job they do, and they do have better recovery time. So because of the smaller incision.
And I have a couple of questions, technical point of view. Do you prefer the local anesthesia during this endoscopic decompression? Local.
No, I prefer regional, at least, because that will relax the whole arm, and then so that I can decompress it, so that I can, when I do the subcutaneous tunnel and all that, I don't feel that the muscle is I want the patients to relax before I can do the decompression.
And when you convert to anterior transposition, do you perform the only subcutaneous transposition by endoscopic assistance? I think it is not easy to all a nerve to be straight during anterior transposition through a small incision. FCU branch is often short, so it interfere with the anterior transposition. We often performed the intraneural dissection of FCU branches to prevent making a new compression site is very important during the anterior transposition. So how do you solve this problem? I think you have a very good skill.
Yes, well, no, I don't really have it. It's just that, well, when you do endoscopic anterior transposition, you really have to, first, you need to be comfortable in doing endoscopic decompression first, so that you have the skills before you go in and dive into anterior transposition, because obviously it needs more techniques. But you can try that in the cadaveric if there is cadaveric workshop, if that is needed. But usually endoscopic, you can see actually, you can see a very good view. You can actually see the whole nerve, how they will, how they run along, and then to make sure it is a smooth route. Sometimes it's more difficult in the open unless you basically open a very big wound. So yeah, so this is what I prefer to do endoscopically if it can be done subcutaneously.
Mm-hmm. Okay.
Yeah.
Another out of topic, I think I wonder about the role of the imaging study. So do you perform the MRI or ultrasonography before the surgery?
No, I don't usually do it unless I worry that there is space occupied lesion, or look at X-rays and that there's something that I worry about. But other than that, usually I don't. So yeah, I if I think that it is idiopathic, then or just OA elbow, I don't do a specific MRI or ultrasound to look for space occupied lesion. Yes.
Mm-hmm. Okay. We have many questions from the audience.
Yes.
So,
maybe.
We have a couple of questions from the audience. So I'll start first with the ones that are addressing the primary carpal tunnel, cubital tunnel, and then we'll go for the later ones regarding the nerve gaps. So a couple of questions regarding.
I can see that we are running late, because yes, I'm sorry, I think I took longer than expected, but maybe should we go to the next sessions, and then I try to type in the answers so that we won't be running too late for this section.
There's some questions that are not they're on the chat. So
okay.
One of them is how to use the tourniquet when you're doing the endoscopic decompression.
How do you use? Yes, I do. I use a tourniquet to do it because I just find that it's much easier to do endoscopic because I can see the view. I can have a better view, a bloodless view. But then I always opt the tourniquet afterwards to make sure that it's good hemostasis.
Okay, I think
Yeah.
you can answer the other question in the Q&A. And then if you
Yeah.
can add some information regarding the use of the facial sling or the anterior transposition during the endoscopic procedure, because it was asked in the chat.
Okay.
Yeah, thank you so much. This was a very nice talk. Now,
Thank you.
we'll move to Professor Tedma. So Professor Tedma will talk to us about the radial tunnel syndrome. Is it fact or fiction? Prior to his presentation, he will show us a couple of questions. So we would need the participants to read the poll and answer, because we will go back to them at the end of the talk, and then he will discuss it with us. So if the help desk can help us with showing the poll that he prepared, the question that he prepared for the participants to answer.
Yuki or Erica, do you have? Okay, go ahead. Thank you. So the question is, how often do you actually encounter radial tunnel syndrome on your annual basis? You can take the answers. And question number 2. How do you diagnose radial tunnel syndrome? In number 3. How do you treat the condition? Bear in mind, it is a fairly rare condition. So with that, I'll share screen with you now, if I may. Well, thanks so much. So today I'm going to talk about the radial tunnel syndrome, fact or fiction. Why did I coin that? It is quite a rare condition. In fact, the condition wasn't recognized until after the Second World War. However, it does exist. In the official coding for the ICD-9, section 354.9, it is now recognized as an uncommon cause of lateral elbow pain. And the cause of that relate to specific anatomy within the radial tunnel itself. And proper treatment will resolve the condition. Why is it a fiction? Some people don't believe that because it's often misdiagnosed as chronic lateral elbow pain. And it's refractory tennis elbow condition. And if you leave it long enough, it becomes a chronic pain syndrome. And because of that, the patients have quite disturbed behavior and often because malingering. The difficulty of diagnosing is quite apparent, and EMG is often negative. The radial tunnel syndrome itself was not actually formally coined and diagnosed until around about 1954 by Michel and Kruger, and he coined the word radial tornado syndrome. Rose and Maudsley in 1972 described it as a resistant tennis elbow.
Professor Ma, you have muted yourself.
Can you hear me now? Let me just check.
Yes, you can.
Oh, good.
Yes.
Thank you so much. So I'll come back to that. It was not until 1954 that the condition was formally recognized and described. And 1993, the radial tunnel syndrome was then described as a posterior interosseous nerve compression by supinator, and this is quite true. The characteristic of the radial tunnel syndrome is rare in terms of incidence. It's probably about 50 to 100 times less common than tennis elbow condition itself. The onset can be acute or gradual. The acute one usually relate to some twisting, injury, or direct trauma. And the gradual onset usually without a cause. What are the characteristics of radial tunnel syndrome? First of all, the patient will describe deep aching pain in the elbow. The pain can be anywhere from mild to moderate to severe, usually moderate. The elbow pain is typically localized, deep to the extensor in the forearm, and they have normal range of motion, but they do have pain and need twisting, turning activity on the load using forearm and wrist. They have weakness of index finger extension. In my view, is more common than middle finger. However, in more severe cases, both fingers are involved. They have weakened grip as a result. The elbow strap that people commonly use for tennis elbow actually make it worse. And sleep disturbance is typical of chronic pain disorder in this particular condition. What are clinical signs? Commonly, not much to find. The elbow range of motion is normal. They do have local tenderness in the extensor muscle just to the radial head. And you can stress the thumb and index and middle finger extension. In extension, you can demonstrate carefully they do have weakness and certainly aching reproducible on the stress test. In isolated radial tunnel condition itself, there's no local tenderness over the lateral humeral epicondyle, unlike the tennis elbow. And similarly, stretching the ECRB has no effects on the common extensor of the humeral epicondyle. And indeed, if you wear an elbow strap, in isolated radial tunnel syndrome itself, it's actually worse than that. That's how you can tell sometimes. And often patient may have two conditions coexisting. This is a diametric demonstration of the elbow tenderness in tennis elbow, quite localized to the lateral epicondyle of the humerus, as compared to radial tunnel, which is further down over the radial head and radial neck region, because where the nerve going through the supinatus region. And this example, that if you actually wear an elbow strap, it actually make a lot worse, and the patient can tell you that immediately. Well, how do you diagnose that? It's really based on clinical history and examination. What's the role of nerve conduction study? Very little, because it's not going to show. A lot of that is actually involved muscle only. And even with needle EMG, you may not be able to tell that, except for a very experienced neurologist. They can actually see a large amplitude on the EMG with no fibrillation or sharp wave. And sometimes you use that in the distinguishing people with cervical radiculopathy, particularly C5-6 level of pinching on the C6 nerve. Ultrasound and MRI is good to use it to assess the nerve morphology and to exclude surrounding compression due to ganglion lipoma. And this is rare. I've probably seen about 3 in my lifetime, so it's how rare it is. The ultrasound guided injection sometimes can be a diagnostic phenomenon. I can use, and I often use that when I'm not sure. X-ray and CT is really to exclude bony pathology related to radial head and radial capitulum joints. Occasionally, if you think there's an autoimmune phenomenon leading to a nerve problem, then a nerve test for autoimmune disorder in gout might be useful. What is the non-surgical treatment? It's really related to activity modification, neurostretching exercises with the hand therapist. I do not find the anti-inflammatory have much role to play at all, often doesn't help. However, like any neuropathy, I advise the patient take some vitamin B6 and vitamin C together, and that seems to help in some of them. What about surgical treatment in the failed non-surgical treatment patient group? Then decompression would be the way they have to consider. But you also need to consider whether the patient have concurrent tennis elbow. If you do, you need to treat both conditions at the same time. If you were to do looking at surgical decompression now, what are the common area of compression related to PIN? First of all, you have the related to the local bone anatomy of the lateral elbow joint in relation to the radial head and around the lash of Henry. These two may give you sensory involvement. More commonly, though, is the fibrosation of ECRB, and more commonly of all the groups is actually arcata frosh, which is approximate edge of the supinator, and sometimes occasionally to the distal edge of supinator. So in terms of the common thing that I see, number 4 is more common, followed by number 5 and number 3. And 3 and 4 do not engage sensory abnormality at all. This example where the patient actually have tennis elbow and the radial tunnel syndrome together. And I've done the tennis elbow condition first, where I scrape the bone, repair the common extensor tear, close that layer and do the extension of the incision, and go between the ECRB and supinator right here. When you get in the area, be careful now. As soon as you see fat, similar to what they see in suprascapular ganglion cysts. When you see fat, that's where the nerve lies. So be very careful here. So you see that, you can see the nerve lying here. Do not try to dissect the nerve. Radial nerve has very special characteristics. The moment you touch the nerve, whether it is in the humeral shaft, radial tunnel, or even in the equivalent releases, they go into neuropraxia. So that's the characteristic of the radial nerve. What do? I do fasciotomy because you really have to decompress the nerve. And that's why you have to learn how to do that. Once you release that, then you close and layer. What do I do post-op? I lift the bandage for 6 days, get them moving straight away off the elbow. After that, the bandage come off and they start local scar management. They can start strengthening program within about 2 weeks. And commonly they return to modified duty, usually within 2 weeks of surgery, and usually return to normal activity by about 2 months, about 6 to 8 weeks. So in summary, it is an uncommon elbow condition, but one you need to consider. Often there's delayed presentation because people don't think about the condition. However, careful history and examination often will tell you that there's something else going on and you need to think about radial tunnel condition. You may use relevant diagnostic tests to help you with that. And I use surgery when conservative treatment fails. When you do surgery, however, you need to appreciate the anatomy. This is quite important. And the importance of hand therapy, post-radial tunnel release, is an important part of treatment. I thank you for your attention.
Yeah, right.
I stop sharing the screen now, just a minute. Okay.
Okay, yeah, it's a radial tunnel syndrome. Yeah, this is a really interesting topic since many people have mixed opinion. So for question number 3, I want to choose number 4. Yeah, I want to refer to Professor Teoma if you live in Korea. Radial tunnel syndrome is difficult to diagnose because there is no diagnostic test to confirm. In addition, the symptoms are very vague. So this is one of the reasons that this is confusing us. So in my short experience, it is difficult to distinguish muscle pain caused by overuse and radial tunnel syndrome. So I have a question. Radial tunnel syndrome is characterized by pain. So I learned radial tunnel syndrome has no motor deficit, but you and other surgeons commented patients with the RTS shows the weakness of the second or third finger extension. So can you explain this symptom again for audience?
I think it is a very difficult condition to explain because it does, and that's why it took so many years for even people to recognize it. It is true that it is a genuine syndrome in that if you're not sure, and often because people present, in fact, in my situation, people present to me usually after about 3 to 6 months when they've gone around so many other surgeons, they couldn't find out what's wrong, apart from the tennis elbow condition. In fact, sometimes because they get concurrent tennis elbow and radial tunnel syndrome, they get that tiny elbow fixed up, the radial tunnel condition persisted. So that's one clue to you. If you really want to do a diagnostic test, you can actually get an ultrasound guided injection of local anesthetic and sometimes with steroid in it. And you should, if this radial is a true radial tunnel, you get immediate release straight away. However, having said that, because of chronic pain syndrome, they often have residual pain elsewhere, but the pain they can tell you is quite different. The other thing you need to consider too, especially in elderly group, they often have cervical spine problem as well. So just bear that in mind. So in other words, you can have a double crush syndrome, one in the cervical spine around the C6, C7 level, and then the radial tunnel syndrome. Similar to carpal tunnel, similar to ulnar nerve in many ways, any peripheral neuropathy.
Okay. We have the results from polling.
We can discuss the results from the poll now.
Mm-hmm.
Yeah,
you can
so
see that it's really uncommon, isn't it? Not many people have seen it. And I do a lot of neuropathy in the nerve surgery. Even then, I must say I'll do about 10 a year. That's a huge volume of nerve I'm doing in peripheral neuropathy. That's good. Second questions?
if we can show the answers to the second one.
Is examined. That's good. EMG, you need to have a very good neurologist who know what they're doing. And even in Adelaide, I only use 2. We have about a few hundred neurologists in town. The reason why it's so difficult, 1 is rare, and 2, they need to understand. To do a EMG on the radial tunnel is quite different to do EMG on the nerve and median nerve. And they need to do enough to know the difference. As I said, really, it's very, very subtle differences in the EMG will show you that, but you need to have very experienced neurologists and ultrasonographer for that as well. So now we've got a bit more time. Any other questions related to radial tunnel? It is a rare condition, but I think it's something that people need to think about. However, if there's not many questions, I'd like to just make a few comments about ulnar nerve, which is far, far more common. Just a word of advice, if you have a skinny patient compared to a well-padded and a big patient in the elbow, try not to do a subcutaneous release in ulnar nerve because they will bang their nerve against the skinny arm and they have recurrence of symptoms quite often. And that's similar to cubital tunnel release using endoscopic technique. It is easier in skinny patient compared to a bigger patient, but the same problem, the skinny patient have less padding in the ulnar nerve. The issue then is what do you do in failed subcutaneous release or transposition? You very have to do a submuscular transposition, and this is still a salvage position in many ways. I learned that directly from Louisville many, many years ago from Harold Kleinet, in that if you had a reliable operation like subcutaneous ulnar nerve transposition, why don't you use that first off? Why do you reserve that as a backup? And from that experience, since my time in Louisville some 25 years ago, I have used it as a principle that I would do that as a primary surgery. And in my hand, the recurrence is very, very uncommon. So something just bear in mind. Margaret is correct. When you do any surgery, including whether subcutaneous or submuscular, watch out for the cutaneous branch. It is unforgiving once you cut it. The patient will complain very bitterly about it. The other reason why I can do endoscopic cubital tunnel release relate to the anatomy of the nerve in this blood supply. All the releases are anterior to the nerve, and you look at surgery at the nerve, all your vascular bundle are posterior. And that's the reason why I can do endoscopic, similar to carpal tunnel really in many ways. There's no structure in front. If there is, for example, in some aberrant vessel, when you hit it, if you don't cauterize beforehand, you won't see a thing. Not only that, you create a local hematoma, causing secondary compression straight away. So this is my advice to people looking at cubital tunnel syndrome. Thank you so much.
Thank you, Prof. So we have a couple of questions from the attendees. So one of them is, how do you differentiate radial tunnel syndrome from that which can be accompanied by ECRB encephalopathy? I mean, lateral epicondylitis. So I think a good number of people would have symptoms of lateral epicondylitis coming together with radial tunnel. Is there a diagnostic differentiation when it comes to the injection? Like, I think, because there is a rule of 9 for injection. So can we rely on this for injection, or is it just like the physical? And then the other question is, if you suspect both of them, do you tackle them at the same time, or you just separate them one by one?
Correct. You can do differential diagnostic tests, separate the tennis elbow condition versus the radial tunnel condition. They can do on separate occasion. And often bear in mind, most of these patients, because they have pain for a long time, invariably they have chronic pain syndrome. So bear in mind that they can tell you the pain relief is very specific. They may not all the pain will go, but the pain that annoy them will subside once you have a diagnostic test. That's how you know. I find ultrasound very useful. MRIs also helps if it's available.
Okay, and then we have one question before we wrap up the session. So the other undiagnosed condition is pronator tunnel and the Sertjes syndrome. Do you encounter them in your practice?
They're quite different again. Their location is different, the presentation is different, and they have very specific pronator syndrome clinical signs to differentiate.
Okay, and then for your preferred method of treatment for that, you just go for facial release. You don't go.
you got to do a compartment fasciotomy. This is a trick. A lot of people don't know that, because if you just go in there, release the compartment, how do you release compartment? By separating the muscle plane, it's not going to release a nerve. You need to do fasciotomy. That's the trick. Yeah.
Okay, thank you so much, Prof. Ma. I think we had a very nice elbow session. I think we're ready to move on to the next session if everyone is okay with that.
Okay, can we move on to the next session, which is the final session of the day? Can we have the introduction screen, please? Yes, thank you. So here comes the final session of the day. I'm Edmund Yao. I'm the moderator for this session, and we have Dr. Michael Mack and Dr. Andrew Chin as speakers, and Dr. Rebecca Lim as the commentator. So the first talk of this session would be from Dr. Michael Mack, who is Associate Consultant of Hand and Microvascular Surface of Prince of Wales Hospital in Hong Kong. And his talk would be on open versus endoscopic carpal tunnel release. Time to you, Dr. Mack, please.
Thank you so much, Edmund, and thank you, Professor Tedma, for your invitation on this very nice webinar. So let me just share my screen here. So I'm tasked with talking about open versus endoscopic carpal tunnel release. For my talk, I'll first start with relevant anatomy, some technical points regarding open carpal tunnel release, some technical points regarding endoscopic release using the two portal technique, which I'm more familiar with, the efficacy of each technique, the risks of each and when to convert to open, and the difficulties that may be encountered in each procedure. So for anatomy, we need to know that the roof of the carpal tunnel or the flexor retinaculum consists of three parts. In the distal part, there is, in the proximal part, there is the distal antebrachial fascia, or what we could like to call the volar carpal ligament, just to make it a little bit shorter. In the middle part, there is the transverse carpal ligament, which is the structure which is most responsible for creating compression onto the median nerve. And distally, we have the aponeurosis between the thenar and the hypothenar eminences. The diameter of the carpal tunnel is narrowest around 12 millimeters. Sorry, just typo, 2 centimeters actually. 2 centimeters from the proximal edge of the carpal tunnel, which is located around the area of the hook of hamate. We have the median nerve just beneath the flexor retinaculum. We have the recurrent motor branch to 3 muscles, the abductor pollicis brevis and the superficial head of the flexor pollicis brevis and the opponent's pollicis. And we're going to talk about the different configurations of the recurrent motor branch according to the Lanz classification. Distally, we have the superficial palmar arch, and we also have on the radial side the palmar cutaneous branch of the median nerve, and we have to take note of all these structures when we contemplate surgery. Looking at the median nerve, it is located slightly radial to midline. So that is the reason why we always put our incisions on the ulnar side of the carpal tunnel, no matter it is an open or endoscopic surgery. We have the superficial palmar arch around 3 to 6 millimeters from the distal edge of the transverse carpal ligament at an average of 4.8 millimeters. For the branches of median nerve, we have a communicating branch in 67% according to Bass and Kleinert in 1999. So on the ulnar side, we also have to take care of any nerve branches. On the radial side, we have the palmar cutaneous branch here, which is at the level of the proximal wrist crease. It is between the PL tendon and the FCR. It is quite constant there. And a bit more distally, we have the recurrent motor branch. And let's have a look at the Lanz classification. It is important to note that there are 5 different morphologies of the recurrent motor branch. It can go usually in 45%, it goes extraligamentous. So this is the one that we are most familiar about, but it can also go subligamentous, transligamentous, from the ulnar side or supraligamentously. So we have to be aware of all these variations, but do not worry too much, because if we look at all these different morphologies, they always arise around the ulnar side of the carpal tunnel, even for the ulnar originating kind of recurrent motor branch. But sometimes they also arise proximal to the carpal tunnel, such as in these variations where they are kind of like an accessory recurrent motor branch. But they're always on the radial side. There are some superficial cutaneous nerves. In this review of 60 patients, they reported 30% poor to fair strength and scar discomfort. And 50% of patients noted a return of some preoperative symptoms. And they suspect that a lot of these are due to cutaneous nerves. In this 1998 cadaveric study, they found a lot of sub-branches of the palmar cutaneous branch of the median nerve, and also the palmar cutaneous branch of the ulnar nerve. And sometimes they communicate around this area where we would like to put our incision. Let's have a look at the classic open carpal tunnel release procedure. It is first described in 1933 by Learmonth, and is now the most frequently performed hand surgery procedure, which amounts in the United States to more than 400,000 cases per year. In a typical open carpal tunnel procedure, we expect a successful rate of 85 to 90%. Patients may experience some kind of grip weakness up to half a year. The indications as compared with an endoscopic technique include acute carpal tunnel syndrome following or before you do an open reduction internal fixation of distal radius fracture. You want to do it at the same time. CTS following some kind of wrist surgery, any space occupying lesion within or near the carpal tunnel you want to tackle at the same time, and any abnormal anatomy, such as some congenital deformities. And if there is muscle wasting, you would contemplate a concomitant tendon transfer, such as the Cam-Meets transfer. Sorry, and in those cases, you may want to do it in an open fashion. So in typical procedure, the incision design is around 6 millimeters ulnar to the thenar crease, according to the chapter written in Green's textbook by Susan McKinnon. This puts the scarring away from the median nerve. It avoids the palmar cutaneous branch and avoids the recurrent motor branch, as we have seen in the previous morphological descriptions by Lanz. If we want to tackle the distal antebrachial fascia, which we do as a routine basis in our center, I will do a proximal zigzag extension from where the wrist crease is. In a typical open carpal tunnel release, we expect a reduction in pain in 70%, a reduction in numbness in 77%, overall improvement more than 70%, and one paper even describes significant improvement in all patients, 89% able to return to previous vocation. For risks, we expect median nerve, flexor tendon, or vascular injury of a combined 0.45%. And one paper described the occurrence of ulnar nerve injury if the incision is a bit too ulnar. The palmar cutaneous branch of median nerve injury can happen up to 25%. However, in the open procedure, we sometimes encounter patients with scar pain, pillar pain, and loss of grip strength, of which these may improve over a period of time, but in some patients it's still difficult to eradicate, and these have been very extensively reported. So what happens in pillar pain? The cause is unknown. Some say that it may be due to ligament or muscle problem. Because most patients have pain on the thenar side, on the hypothenar side, or on both sides, it can be due to problems with the transverse carpal ligament after it has been divided, losing the tension, problem with palmar aponeurosis. Secondly, can be due to change in carpal arch morphology, neurogenic. Could it be injury to the cutaneous branches of nerves or effect on Pacinian corpuscles? or can it be edema of carpal bones on both sides? All of these have been described. So people have been starting to think, if we avoid a division of the palmar aponeurosis, can this pillar pain can be alleviated somehow? So that brings us to the development of a limited OCTR, or the LOCTRA, or the endoscopic carpal tunnel release using a single or double portal. So this is Dr. James Strickland in 1992. He described a method of using the indianatome to perform the limited open carpal tunnel release, or LOCTRA. So in his method, a 1.5 cm incision was made starting from around 5 millimeters just distal to the transverse carpal ligament. And with the succession of several of these different sized indianatomes, the carpal tunnel, the transverse carpal ligament is successively divided. And this is the size of the wound after this procedure. In the endoscopic carpal tunnel release, which I'm going to elaborate in a little bit more detail, was actually first described in Japan in 1987, but subsequently popularized by James Chow in 1989. So we have to take care of some of the anatomical landmarks, including the hyperabducted thumb line, which is this one here in red. This marks the position of the superficial palmar arch. The radial border of the ring finger has to be the reference point for our both portals. We have to beware not to place our distal portal distal to the hyperabducted thumb line to avoid injuring the superficial palmar arch. And the ulnarly located incisions will keep us safe from the palmar cutaneous branch of median nerve, which is typically between the palmaris longus and the FCR. So the proximal portal is just ulnar to the PL tendon at the level of the proximal wrist crease, taking care of cauterizing the superficial veins. The distal portion of the antebrachial fascia is divided, and a synovial elevator is inserted to free the undersurface of the transverse carpal ligament. We have to make sure that we can feel a washboard sensation very well, because that is the small area, the plane, that we are going to put our instruments between the TCL and the underlying flexor mass. The wrist is put in an extended position, and the trocar cannula is directed towards the distal portal. Actually, if this is correctly placed, the whole instrument has a protective effect against the superficial palmar arch and the rest of the branches of the median nerve here. So everything we cut within the trocar cannula is actually safe from the vital neurovascular structures. And then using the trocar cannula, there is a slot in between, and when we have to make sure that we visualize the transverse fibers very well before we use the retrograde knife to divide it. So we have to confirm a complete release of the deep forearm fascia proximally, the transverse carpal ligament, and the aponeurosis between the thenar and hypothenar muscles. So just to show a little bit, first we mark out where we're gonna incise. We inject local anesthetics. So the proximal portal is just ulnar to the PL tendon. The distal portal, I use my thumb to feel for the transverse carpal ligament, and around 4 to 5 millimeters distally, I designed the distal portal along the radial border of the ring finger, and making sure that this distal portal does not go more distal than the hyperabducted thumb line. This is very important. So the volar carpal ligament is divided. We make sure that there is a washboard feeling, and most importantly, we use the blunt dissecting instrument to make sure that the undersurface of the transverse carpal ligament is adequately freed from the flexor synovium. This is the insertion of the trocar cannula. The thumb is very important in this step because it protects the trocar cannula from hitting onto the superficial palmar arch. So for this step, I think here my resident is doing it with the wrist a little bit in a neutral position. I think the wrist can be a little bit more extended in our usual practice to facilitate this insertion step. Then the TCL is divided with a retrograde knife. So the videoscope is is inserted from the distal to proximal. And then the knife is inserted from the proximal portal. And here you can see the insertion at the yellow-white junction. And the whole transverse carpal ligament is well seen and then divided at a magnified view. This magnified view is very important because it makes sure that we are really cutting what we can see. This is the transillumination test. After we have divided the TCL, this test can help us confirm the completion of the division of the TCL. So how does LOCTRA compare with ECTRA? In this study, they documented no significant increase in the amount of nerve injury between the two methods. And this is a study performed in 2003 in our center by Dr. Wong, who is now actually a tumor surgeon. So between 1999 and August 2000, 30 patients with bilateral CTS were recruited. They were all confirmed by NCT and all had simultaneous bilateral release using both methods on either side in a randomized fashion. So simultaneous procedures using either ECTRA or LOCTRA using the Indiana technique. So we had 28 females, 2 males, 30 patients and 60 hands, all bilateral CTS and no significant difference in demographics with minimum follow-up 1 year. Interestingly, we found that, first of all, there was no neurovascular injury. The amount of complete symptom relief and partial symptom relief was actually similar in both sides. The operating time, skin length was similar. However, we found that, interestingly, the LOCTRA group had a slightly better post-operative scar pain and radial pillar tenderness compared to ECTRA. And actually, patients preferred LOCTRA a little bit more. So the conclusion of this study was that LOCTRA had similar efficacy to ECTRA, but it resulted in less scar pain and less pillar pain in the early post-op period. However, in the long-term or medium term, there was no significant difference. Mini open or LOCTRA may seem to be the winner, but actually there was some cases of median nerve injury and FDS tendon injury when performing LOCTRA, whereas in ECTRA, I think because of the magnified view, you're actually cutting what you can see, and you can probe the TCL, you can see the TCL, and you can feel it when you cut. So in my practice, I prefer the ECTRA two-portal technique. It results in less scar problem and increased safety. And actually, in LOCTRA, you can't actually see what you're cutting very well. In this meta-analysis of open versus ECTRA, they identified 28 RCTs and found that ECTRA was associated with significantly higher satisfaction rates, greater key pinch strength, earlier return to work times, higher transient nerve injury rates, but a similar long-term nerve injury incidence. Is ECTRA contraindicated in wrists or palms with previous surgery? This patient had an SL reconstruction previously done in a mini open arthroscopic assisted method. Should we go for open straight away or attempt ECTR first? Well, I tried ECTR on this patient, and actually the TCL fibers are still quite well seen. Are additional decompression procedures during open release useful? Internal neurolysis, longitudinal epineurotomy, flexor tensinorectomy, and Z-lengthening retinaculoplasty were shown to not have any additional benefit. What about when tendon transfer is required? I think that if we use FDS4 transfer, we can still do ECTRA at the same time. So it is not a contraindication. And this shows the procedure under local anesthesia, confirming the presence of palm abduction. So indications are shown as such. I don't think that accessory muscles or previous surgery around the area are absolute contraindications, but I would do an open for recurrent cases. So in summary, I think endoscopic carpal tunnel release is my go-to procedure, but we have to know all the vital structures, where they are, mark them out, only cut what you see directly. Do not force it when uncertain, convert to a proper open technique, and make sure the instruments are working well, including the scope, and make sure the retrograde knife is not too blunt when you reuse it n number of times. That's it for my talk. Thank you.
Hello. Hi, Michael. Thank you for giving such an enlightening talk and for all your really great videos as well as photographs. So I think that carpal tunnel is a very common condition, and this is something that all of us see very much in our practice. So I just have a few questions. Let me just check the polls. Okay, we do have some questions from the audience. The first one is CAMIT's transfer performed these days? I think the answer is yes. I think Michael actually gave a presentation on the FDS4 transfer, but CAMIT's is the PL to APB transfer. It's still performed these days. So just maybe the first question would be to Michael, for your choice of potence-plasty for carpal tunnel, what do you actually routinely do? Just as a general guide.
Okay. In my own practice, I routinely do the FDS4 because I'm more prone to favor minimal invasive procedures. So I like that we don't have to open up the central part of the palm when we do the FDS4. I like it that the FDS4 is quite strong. It has good excursion and it's agonistic. Although I think the CAMIT still is pretty good actually, because when we think about it, the way that we activate the PL tendon is by opposition. So if we do opposition, we can immediately see the PL tendon activating. So I think it's even more agonistic than the FDS4. But I like the more minimal invasive approach for the FDS4 plus ECTRA.
Okay. All right. And then we do have another question from the audience. So in your experience, what is the best timing for carpal tunnel release for better outcomes regarding with regards to pain and grip strength?
Okay. For those patients who fail conservative treatment, I think I would go straight away for surgery. Because unlike cubital tunnel syndrome, many of the patients with early carpal tunnel syndrome without motor deficit, before they develop any motor problems or muscle wasting, they actually, some of them are quite responsive to conservative treatment. But in those who fail, I think without a doubt, we can go straight for surgery. Particularly, it's simple and it's low risk, and it can be done under local.
I'm just wondering, how long do you actually trial the patients for conservative treatment, and what kind of conservative treatment do you actually routinely put your patients through?
I will teach them nerve gliding exercises myself, and I'll give them light splints. Because of clinic waiting time constraints, we are not allowed to see them, very frequently. So unfortunately, I think we have to give them a period of around 6 months to try conservative treatment.
Okay, and just a question, a technical question. Do you think the size of a patient's hand actually matter in your choice of release, whether you choose endoscopic, limited open, or just open?
Yeah, I think yes, very much. The instruments we're using actually date back to the original things that James Chow were using. We started using these instruments in 1991, and they're a bit old, yes, and they're designed for Western patients. So in Chinese women with tiny hands, it may be a bit difficult in some patients with narrow carpal tunnels. So if somebody can come up with a small cannula, a slightly smaller retrograde knife, that would be great. Yeah.
Do you think, Edmund? Could we move on to the next speaker? Thank you, Michael.
Thanks, Michael.
Thank you.
So our next speaker is Dr. Andrew Chin. He's from Singapore. Can we have the introduction slide, please? He is at present the Director of Wrist Surface of the Department Hand and Reconstructive Microsurgery of Singapore General Hospital. He has vast clinical experience in wrist surgery for more than 15 years after his training in renowned European centers. And he is a dedicated educator. He took up a lot, numerous appointments in professional association like APWA, IWAS, Singaporean Hand Surgery Society, and also AO Trauma. And his talk today would be on a failed carpal tunnel syndrome surgery. So time to you, Dr. Chin, please.
Thank you. Can you hear me?
Yep.
Okay, can I share slide? Thank you. Thank you very much, Professor Ma, for your kind invitation. What stands between you and the next activity is me. So I would try to keep this short. Failed carpal tunnel syndrome surgery. I have no disclosure for this talk. Right? What's the current situation? As my colleague Michael has already told you earlier, it's the most common compressive neuropathy in the periphery with a prevalence of about 3 to 16 in most population studies. Surgical decompression is one of the most common hand surgeries performed, and the success rate has been high, around 80%. Surgery is pretty much effective treatment modality, and however, but patient satisfaction is not universal. Surgery for failed surgery, surgery for the failed carpal tunnel surgery is about 2.7%, and 2 to 10% require revision surgery for recurrence. So the statistics is actually quite a bit if you consider worldwide data. So for carpal tunnel release, we have to understand that it's actually one of the relatively straightforward and simple operations technically. Relatively, that's the key word. However, there's also fraught with potential dangers and pitfalls. In a rather small space, you have very important structures, which my previous colleague has alluded to. They run deep and around the transverse carpal ligament. And failure to appreciate this anatomy will compromise the surgical safety and eventually affect the patient outcome. So what do we look for in the anatomy of the carpal tunnel? The close proximity of structures to each other. These are the following: the palmar-cutaneous branch of the median nerve radially, and ulnarly you have the ulnar nerve and artery as well. Common digital nerves are the ones that you need to worry about distally. As you can see from this cartoon, right? These are the things that you need to be aware of. And there are also various variations in anatomy, which Michael has succinctly put it, right? They can be either extraligamentous, subligamentous, or transligamentous, all right? And these are actually the percentage of this anatomy, the variability within this study that was done in 1974. So what type of surgeries do we have? The options are release, and some people actually, they extend the carpal tunnel to do a tenosynovectomy as well, especially in the older surgeons, which I actually noticed some of them actually do more than just a simple release. Minimally invasive endoscopy as well as mini open, as what Michael has mentioned. Single double portal, right, as described by AG and Chow. They started way back in 1990 for AG and Chow in 1987. Knife light and other equivalents have also been sort of discussed. Right, knife light is actually a mini, it's an instrument that allows the surgeon to just do a mini incision and to be able to complete the rest of the release through that small incision. And other authors have also subsequently invented new devices, such as our Thai colleagues for this miniature, and the Malaysian colleagues in 2019 with a supraretinacular endoscopic carpal tunnel release. So what are the recommended incision, right? As Michael alluded to, we need to make sure there is a more ulnar bias, right? And it's a 6 millimeter ulnar to the thenar crease and in line with the ulnar border of the middle finger. So there's a landmark, right? Too radial, you risk injuring the palmocutaneous branch of the median nerve and the recurrent motor branch. Too ulnar, you risk going into the Guillen's canal and injuring the ulnar neurovascular structures. So what are the complications then of carpal tunnel release? You have direct injury to the anatomy, be it nervous, vascular, or tendinous, as you can see from the list of potential structures that can be injured. You have soft tissue complications such as hematoma, infection, skin necrosis, or scar hypertrophy, which can happen. And if it's indeed a deep infection or very tense hematoma, you probably need to do a emergent surgery to deal with these soft tissue complications, which can be either immediate or even earlier. All right, pain, you have CRPS, chronic regional pain syndrome, and hypothenar pillar pain, the so-called pain that's adjacent to the incisions, which can also be quite debilitating to some patients, and sometimes it takes about 3 to 4 months to get better. Others like flexor tendon bowstringing, which was described back in the 70s by Dave Lickman and his group. Wrist instability, if you extend all the way ulnarly, you can actually compromise on the piezotriquetral joint. Of course, persistent and residual symptoms, which I will deal with later in this situation of failed carpal tunnel release. You can have persistent compression, recurrent compression, or you may have alternative diagnosis, which can give rise to similar symptoms as the carpal tunnel syndrome. Right, so open versus endoscopy. I'm not going to touch too much on this. In fact, Michael has actually talked about it, but I just want to highlight the point about this particular study done by Bockstein and Sorensen in 1999, where they analyzed 54 publications in this systematic review. Okay, they actually say that they're comparable, both endoscopy and open surgery. But what we want to highlight is actually the rate of irreversible nerve damage, although similar, but the catastrophic complication with endoscopic release actually slightly higher, where things like complete transection of the median nerve, right? And of course, reversible nerve problems are more common after the endoscopic release. But however, the rates of other complications such as CRPS, hematoma, wound problems, they were actually similar between both techniques. So whether you prefer to do endoscopically or open release, right? Slightly higher risk of injury to structures for endoscopy, but certainly not much difference in terms of the complication rates. All right, so back to the failed carpal tunnel surgery. These categories are actually first described by Susan McKinnon and Tong back in 2001, where you have patients coming with persistent symptoms even after compression, so there's actually no relief at all. So this can be attributed to things like incomplete release of the flexor retinaculum, incorrect diagnosis, or other sites of compression, or irreversible nerve pathology. The second group will be that of recurrent symptoms. So after a period of relief, they get symptoms of carpal tunnel syndrome again. So most of the patients have been found to have mainly diabetes, or they have some perineural adhesions that can arise after having the release because of scarring and development, and you have the development of secondary compressive symptoms. Of course, there are also entity where you have new symptoms coming in, where it's different from the preoperative symptoms, such as incomplete release with a focal compressive site, whereby only maybe certain areas of the distributed sensory areas are affected. And iatrogenic complications can also be vascular in nature. So we need to be aware of such things. All right, so Zhang in 2019 wrote a paper, and he actually actually sort of divided into 5 I's for the causes of this failed surgery. Inappropriate expectations, whereby actually the patient already have very severe carpal tunnel syndrome when he presents, and whatever surgery that you do may not actually be effective because most of the nerves are already irreversibly damaged by the time he comes to you. Incomplete release of carpal tunnel, yes, that's what we mentioned earlier on, to get the persistence of symptoms. Insidious recurrence from scarring, which I already elaborated earlier on, where you get things like recurrent carpal tunnel syndrome. And iatrogenic nerve injury, which unfortunately this can result in patients coming in with debilitating symptoms, and they usually present immediately after surgery. Okay, inaccurate diagnosis. Other differentials that may mimic carpal tunnel syndrome, such as arthritis, neuropathies, metabolic diseases like hypo or hypothyroid, inflammatory arthritis, neoplastic, so you have space occupying lesion from tumors. You can also continue to have persistent symptoms, right? Such as this lipoma within the carpal tunnel, which is also rare, but certainly we do have to understand that these things do cause persistence in symptoms. Double crush syndrome, right? Such as proximal nerve compressions, be it at the nerve roots, the brachial plexus, or even a higher median nerve, higher up in the median nerve, such as the pronator lacetus fibrosis. So these are important things to be aware of, so that you don't miss out. All right. So this is a cartoon to depict a typical double crush, where patient actually has cervical spondylosis as well as carpal tunnel syndrome. Very, very common. Right, so a poor question. For revision surgery secondary to scarred median nerve at the carpal tunnel, what will you do after a re-release? Is neurolysis, no further surgery, neurolysis, and commercial wrap, neurolysis and autologous wrap, neurolysis and hypotenar fat pad flap, neurolysis and regional or free flaps. Can we move on? Yep. Okay, so majority of them will actually just do a neurolysis and stop there, right? Next one will be hypotenar fat flap, which is quite common. All right, thanks for all your feedback. All right, so management of recurrent CTS. Okay, this systematic review by Jensen et al., right, shows that there are 5 different groups that are being analyzed. Those who had revision decompression with or without neurolysis, those who had autologous fat transfer, those who had resurfacing of median nerve with hypotenar fat flap. The other group will be pedicle free flap and others such as use of commercial wrap. So all groups actually show clinical improvement. Those with the hypotenar fat flap and autologous free fat graft shows the most improvement in both the Boston carpal tunnel questionnaire and the visual analog scale for pain score post-operatively. All right. So actually, whatever you do, there is actually clinical improvement. All right. So these are the choices which there's no right or wrong, but certainly these are the various choices that you can consider for patients coming with recurrent CTS. All right, so these are the typical treatments that we use. Some authors have actually used this commercial wraps. The good thing about it is there's no donor morbidity if you are talking about fat, the flaps that we are using, right? It's actually just using the commercial wraps from where they actually use so many different types of materials, be it from bovine source, porcine source, or even human amniotic membranes, or sometimes it can just be reconstituted compounds like a hyaluronic acid with carboxy methylcellulose. All right, synovial flaps have also been used. All right, the synovium from the flexor tendons, the deeper flexor tendons, can be mobilized to sort of cover the median nerve after neurolysis to actually sort of reduce the incidence of scarring post-operatively. And so these regional flaps also, be pedicle or even free flaps, have been used for the same purpose. All right, hypothenar PET flap as popularized or described by James Strickland back in 1996. Right, it's a very popular kind of procedure that we normally use for treatment of patients with a very scarred nerve and coming with recurrent symptoms. All right, so this particular case I want to share with you is done with my colleague, where a patient had a recurrence and worsening of symptoms 8 years post-release. The nerve is tethered to the volar and radial aspect of the carpal tunnel. You can see the dense adhesions of the median nerve to the radial wall over the lower left picture, and the hypothenar fat flap was raised. You can also see that the palmocutaneous branch of the ulnar nerve is also present. So we take pains to actually make sure that we protect the nerve. All right, so post-neurolysis, the nerve is gliding well, as you can see from this video, right? So we have freed up all the adhesions. Okay, and then the fat pad is swung over to cover the volar and the radial aspect of the neuralized nerve. Okay. So in summary, carpal tunnel surgery is one of the most common procedures performed. In tandem, there's a significant number of such procedures that may not lead to a good outcome, resulting in failed surgery. Such patient usually presents with persistence, recurrence, or development of new symptoms. Just remember the 5 I's for causes: due to inappropriate expectations, insidious recurrence, incomplete release, inaccurate diagnosis, iatrogenic injuries. And diagnostic workup for such failed surgery will include detailed history, physical examination, review of post-operative notes, preoperative tests, results, and imaging, and assess the time interval of occurrence of symptoms after surgery. And of course, revision surgery options will include revision carpal tunnel release with or without neurolysis, repair of iatrogenic injuries, release of proximal sites of compression, excision of space-occupying lesion in the carpal tunnel, nerve wrapping, be it a commercial or even autologous vein wrapping can be done, or flap surgery, as was described for nerves that are scarred or ischemic. With that, I thank you.
So thank you, Dr. Chin. Very comprehensive talk on failed carpal tunnel syndrome surgery. Before we move on to the question, I have a few points to clarify with you. May I clarify that when you said in the poll question, you said commercial wrap, do you mean those commercially available nerve conduit?
No, not nerve conduit, but the wraps that we do for adhesion prevention. Things like separ film, things like even those that looks a bit like a transparent flap, but it's actually made out of things like hyaluronic acid or even metacellulose. Yeah, those type.
So they're purposely made for scar prevention.
Or minimization of scarring. Yeah.
I see. So one question for you. How do you manage occasional significant scarring and the CRPS post surgery?
CRPS, sometimes there's type 1 and type 2, right? So type 1, we don't know what the cause is, right? It can happen. Certainly we need to detect early, look out for signs of early CRPS, okay, before it becomes mortal and patients have a very cold hand that's already quite late. So I would usually just do blocks and whatever, right? We'll give a patient blocks, and then if need be, admit him or her for block over a prolonged period of time, and do some gentle mobilization, nerve gliding exercises. These are important things. Of course, type 2, as you know, if there's a cause, you cut a nerve, there's no brainer. You go in and repair it. Yeah.
Yes. Another question is on the use of cortisone. Do you think, have you ever tried using steroid at the time of surgery to reduce scarring?
No, I don't. I haven't been using steroids in my practice, although I've seen some of my colleagues have done it. But in my personal practice, I don't. In fact, I don't even use steroids at all. I just for me, it's not within my armamentarium. But of course, it's been described in the literature as a pretty effective treatment modality. Yeah.
Thanks. Rebecca?
Yeah,
Seems like there's a question from the audience.
Yeah, so Andrew, thank you for the talk. I just want to find out, is there a standard pre-op workup you use for ongoing symptoms? How do you decide if the patient is having a recurrence after a previous carpal tunnel relief? What's your timeline and all that? Okay, so recurrence is defined as a patient after operation symptom-free for at least 3 months, and after 3 months start to develop
carpal tunnel symptoms again. So I do encounter maybe in my years of practice, probably less than 10 with that. Doesn't mean my surgery is good, but maybe the patient got fed up and went to see another doctor. I'm not too sure about that, but certainly, right? I have to be cognizant of the fact that yes, we need to do a proper workup. So a thorough history is important, and if the patient had a surgery done by you, I think it augurs for you to actually, or behooves for you to actually go back and see your op notes, what you have done, and certainly if the patient had nerve conduction study done for the first surgery, you may want to repeat one just to see any changes in the nerve conduction study as well, to help you to come to a conclusion. Of course, most patients coming in with a persistent symptoms, that means the patient has no relief of the symptoms, be it before or after surgery, then it's most likely due to incomplete release of the carpal tunnel. I've come across quite a few of them. Personally, I have 3 cases of incomplete release in my entire period of practice, and I've also seen other colleagues who referred to me for this problem. So it's not uncommon in that sense, because I deal with it. I've seen quite a bit of it, and of course, it just behooves you to actually do a completion release. And of course, adjuncts such as ultrasound scan does help, because ultrasound scan can actually determine whether you can still have evidence of flexor retinaculum that's not been released. And of course, the nerve that has still persistently enlarged or swollen distal to the compression, it also tells you or gives you a clue to say that the nerve has not been actually completely released yet. Yeah.
Oh, we do have one more question from the audience, just asking if you usually advise patients to take vitamin C as CRPS prophylaxis routinely for nerve releases, CTR or any other.
I don't, because for me, my personal experience with CRPS on carpal tunnel releases are not common. In fact, probably less than a handful. So I don't routinely give vitamin C. But certainly, if the patient had a history of CRPS before, yes, I would do it. Yep.
Okay, then maybe one final question. What is your post-op rehab regime for post-recurrent carpal tunnel release?
Okay, so sometimes depends on what the cause of the recurrence is. Of course, if it's just a space occupying lesion, there's no problem. Just remove the thing, and patient just will start early mobilization. But for those who are very scarred or whatever, things like that, so you tend to be a bit more cautious. I will tend to, of course, nerve gliding exercises. I will still continue to do so, passive stretching and finger mobilization, all this to get the tendons moving, and also indirectly the nerve to glide is important. But also to monitor the patient at every step of the way, because and also warn the patient to manage the expectations, because multiple surgeries means you get more scar, right? Formation. So after the patient's been operated the second time round, you expect scar to reform again. So there's also a high chance that patient may also get a recurrence, so to speak. Yeah.
Okay. Thank you, everyone. That's probably the time. May I hand it back to you, Professor Ma, for a wrap up?
Thank you so much. I'll share screen with you now. Well, what a session, isn't it? Really looking at all the different nerves that can go wrong in the body and the upper limb, and how we deal with that. Just a comment on Andrew's dealing with the scar nerve. I agree with him. I think the neurotube, I find it more and more useful for scar nerve. The one that you neurotube use for join the nerves together, you can actually use that to wrap the nerve around and actually minimize your scarring. I do tend to use a lot of cortisone at the time of surgery to minimize that, rightly or wrongly, but that's my routine and it has worked for me. So thank you all for joining, and I'd like to thank all the moderators and speakers, commentators, and supporting staff in the audience for participating. We have about 700 people enrolled, and at the last minute, just before we finish, you have about 300 people still on the webinar, looking at you quite interestingly to keep up with the whole session, which is great. And there are many more on YouTube and Auto TV. The society runs 6 sessions of webinar this year, 3 with traditional education similar to what we have now, and 2 with combined with other sections and societies, and 1 with the APOA Congress in Manila in the Philippines. Later on this year, you'll get more information about it in due course. Please fill up the post-webinar questionnaires so that we can send you a certificate of attendance. I welcome all the new members who want to join us as APOA Hand Up Limb Society, and certainly would encourage any active members of the association to participate, either as speakers, moderators, and any other format that you can want to participate. Commentators, for example, would be very helpful to us. If you want to join us or want to participate, flick me an email and I'll link you up to the group accordingly. Just to introduce you to the group, I'm the current president, and Professor Im Ho Jeong. I think, unfortunately, he's tied up in surgery right now. He's the president-elect. Margaret Fogg, which I heard today, is the honorary treasurer. Dr. Iman Aminata from Indonesia is the general secretary, and Professor Moin Sung from Korea is the education chairman, who organized many of this webinar. And Professor Chalawish from Thailand is a symposium chair. We have many other members who are working in background, for example, as members of the education committee, to help to set up many of the webinars that we have been running. The next webinar is a combined meeting with the APOA trauma section. It's going to be held on the 19th of March, similar time, 5 p.m. Kuala Lumpur time. And there will be a combined input from the trauma section and hand upper limb section. The order, again, is in shoulder, elbow, and wrist and hands. The first part is on the 4-part shoulder fractures and the total and reverse arthroplasty versus fixation. And then talk about fixation or replacement when it doesn't go well. This is really more of a case-based discussion. The elbow section will focus on a common intra-articular elbow fracture, and then elbow replacement for the elderly in osteoporotic fracture, tips and tricks. And lastly, in the hand section, we talk about complex distal radial fracture and distal radial fracture with DIUJ instability in the role of wrist arthroscopy, etc. So I hope you can put that in your diary and do join us for this particular session. You can follow us on social media. And as I say, if you really want to participate in our activity, please let me know and I'll link you up directly. To that, I'll say good night to you all and goodbye until we meet again in March. Thank you all for your attention. And thank you all the moderators, commentators, and speakers for your participation. Just a final word, when we're waiting for the audience to log off and all the staff member involved today, please stay on so we'll have a quick review shortly after. Thank you so much. Good night and goodbye.
Bye. Thank you.
Thank you. Bye-bye.
Thank you. Goodbye. Perhaps we can have a group photo.
Yeah, I think so. Why don't we everybody come on?
Yeah,
all the speakers, moderators, everyone. We take a group photo and we can post it in our newsletter later. Erica, you want to set a group photo for everybody?
Yeah. Everybody's ready. Mbak Nis, tolong ya group foto. Oke.
Ya, dokter.
Ya. Dihitung, Mbak. Okay, 1, 2, 3. Again. Hold, please. 1, 2, 3. Okay.
Thanks so much.
Very
You
much.
can post that to all the speakers, moderator, please, Debbie or Erica.
Yeah.
Yeah, we're just waiting for the lock off now, so they are still quite a lot of people on it. Just wait for a few minutes. 조용해야 돼.
Professor Ma, perhaps it's very late in Singapore and Japan. Can they take some rest and
Of course.
leave the Zoom?
Well, sure, you don't have to. I think, thank you so much for taking part in tonight's webinar. And it has been very successful from many perspectives. And thank you for your hard work in that. I know it's late, so if you want to excuse, by all means do so. We will send you some information about the actual number of attendees. That will take a few days because we need to collate the data from outside the Zoom area, like Auto TV and so on. There will be some questions that probably still need to be answered after the webinar. If you could do so, so that we can post them on the web for them, that'd be great. And also encourage perhaps your juniors to join in, either looking at the recording for this particular webinar, or perhaps in the future. And I certainly welcome you all to join us as members of the APO Hand and Upper Limb Society. It's not meant to be a competition with a local society at all. It's really meant to be a collaboration, in fact, international collaboration in hand upper limb surgery. So thank you. If you have to, if you're feeling tired, you want to excuse, please do so. And I thank you again for your participation.
Thank you, Ted. I'll take my leave.
Thank you.
Thank you so much.
Thank you.
Thank you, everyone.
Thank you.
Thank you, everyone.
Bye-bye.
Thank you.
Thank you.
Bye-bye. Thank you.